All right. So, I need that. I thought we'd do something a bit different for this session, just to kind of break things up in terms of whether or not everything is didactic or more interactive. Had a little bit of that with the last talk that I gave on circadian rhythms, but this one, the entire interactive. So, if you don't mind, on your devices, and fine, you can just watch, but on your devices, if you want to play, to www.kahoot.it. Okay? And when you get to that, and again, that's www.kahoot.it. And when you get there, when it asks you to enter your name, just because this is for fun, this is your chance to be Wonder Woman or James Bond or things like that. So, yeah, you don't have to, because it will pop up names on the screen as to who got it right, who got it wrong. So if you've already typed in your name, just click back and then go back in. But you can make up any name. It's also your chance to be John or Sue. So you can just put in anything and just follow along for fun. Or if you're low tech, you can always just take a scrap sheet of paper and scribble down your answers there, and you'll see if you were correct or not. But it's kind of an interactive quiz, so we'll talk about that. All right. Okay, we've got a couple people signed in. It'll take just a minute. I like the names. And does everyone see the game pin up top? They're the 8914731. All right. Raise your hand if you're still signing in. Okay. No rush. Just want to make sure. Yeah. I don't think so. Yeah. All right. Anyone else still signing in? Okay. Wait another minute. Oh, yeah, just have to type in that game pin. We can get started with some fun questions. All right. Is everybody all set? Anybody else? Oh, okay. Okay, no worries. It won't let some people in? Oh, gosh. Okay. Oh, okay. Must have been something with the internet connection. Okay. Is everybody in now? No, still got a few popping in. All right. Are we? Oh, I think another one popped in. All set? Anybody else still trying to get in? Is everybody in? All right. Well, we'll go ahead and get started. And again, if you're not, that's fine. You can just answer in your head. It just being on the screen is just for fun, really. All right. So we'll call this Sleep 101. It's about a lot of different topics. All right. So it looks like we're having internet connection issues. On the Ramsey guest? I am not sure. Okay.
Yeah, jump on the 5G one.
We're here?
Yep.
Is that? Okay.
And then it's travel, no uppercase, travel 11. Say no.
Okay. Okay. Sorry about that. All right. So here's the first question, and don't worry about the timer. We'll extend that because of the connection issue. Which of the following is not seen in aging? And after this first question, let me know whether you want me to read the answers or not, if that makes it harder. Decreased slow wave sleep, prolonged sleep onset latency, decreased stage REM sleep, or unchanged delta sleep amplitude. Okay, sorry, that our connection issue kind of messed up that question, so not many people had an opportunity to answer. So which one of those is not seen? It's not so much a prolonged sleep onset latency that you see. It's more of an issue with increased wake after sleep onset. With aging, and it'll show you on here what your scores are so far, but again, just for fun. All right. So in general, with aging, you don't get a change in REM latency or sleep onset latency so much. The delta sleep amplitude, the degree that you see those slow wave sleep and delta sleep, is unchanged. As I mentioned earlier, they tend to have increased wake after sleep onset, and therefore, obviously, a decreased sleep efficiency. Because of all that, that tends to increase fragmentation, which of course leads to increased stage N1 and N2 sleep, and therefore, in general, you get decreased stage N3 or slow wave sleep and stage REM sleep. With aging, you do also tend to get decreased melatonin levels and increased daytime napping. All right, so this should work better. By the way, is it more helpful if I read the answers when the question pops up, or do you prefer to read them on your own? Read them? Okay, will do. All right. So which association pairing is not correct? The pineal gland synthesizing melatonin, the suprachiasmatic nucleus being the circadian rhythm generator, histamine action leading to sleep promotion, or hypocretin/orexin leading to wake promotion. Got some answers coming in here. All right, so the answer is histamine and sleep promotion. If you think about it, antihistamines like Benadryl, those kind of medications, what do they tend to do? They tend to cause people to be sleepy. So histamine is actually involved in wake promotion. The easy way to remember that is if you've ever had a very prominent allergic reaction or urticarial reaction, the hives to something that you've been exposed to or something, if you think about what an intense inflammatory kind of situation that is, believe me, you're wide awake. So That's the net result of histamine, is to cause wake promotion, as is hypocretin. The mechanism involved with the deficiency of which is involved with type of narcolepsy. Okay, and the other associations with the nuclei and pineal gland are from our talk earlier. Okay. All right. So, and the faster you answer, the more points you get. So that's part of the fun competition too. Which is the proposed substance S that increases throughout wakefulness, leading to sleepiness at night? So this is kind of a cellular accumulation. There are kind of two things primarily that drive sleepiness: substance C and substance S. Substance C being and substance S being this intracellular substance. Is that proposed to be glycine, GABA, dopamine, or adenosine? Got some answers coming in here. Few more seconds to think about it. All right, it is adenosine. That is the substance that's proposed. And it's interesting because how does caffeine lead to wakefulness? Well, caffeine blocks adenosine receptors. So that's the mechanism by which it's proposed to lead to increased wakefulness. So just kind of an interesting factoid there that really gets at, how does caffeine work? All right, let's see if we've changed around here. Okay. All of the following occurred during an apnea except bradycardia, or a slower heart rate, the cardiac output, how much the heart actually beats and pumps out per beat, increases by about 1/3. Blood pressure decreases early, then increases later in apnea and in the post-apnea period. Or you get increased systemic vascular resistance. That's where your blood vessels clamp down more. Okay. Okay. Got some more answers coming in here. Just a few more seconds. All right, and you're exactly correct. Cardiac output decreases by about 1/3 as a result of apnea. You can get slowing of the heart rate. Okay, so symptomatic bradycardia at night can be a result of the apneic episode. During an apnea event, the blood pressure does tend to decrease early and then increases later during the apnea and after the apnea has occurred. And certainly with the sympathetic nervous system discharge you get with the norepinephrine release, you do get that increased systemic vascular resistance from the vessels clamping down. All right. A Vols fan is still in the lead. All right, which of the following is not a way that apnea is associated with stroke risk or cerebrovascular accident risk? A 15 to 20% reduction of cerebral blood flow during an apnea, cumulative effects leading to thickening of blood vessel walls over time, over years, increased fibrinolysis, or intermittent hypoxia leading to increased inflammation. Got a few answers coming in. All right, so very good. A lot of people got this right. Increased fibrinolysis. You actually get decreased fibrinolysis with sleep apnea, and specifically during an apnea. Fibrinolysis is where your body acts to break up clot. Okay, that's where it severs those fibrin connections. So yet another way it can increase stroke risk. No question, untreated sleep apnea increases inflammation. That leads to a lot of different things. Vasoconstriction repetitively, prothrombosis, increasing clot. It causes endothelial damage, damages that inner lining of the blood vessels and actually kind of the middle layers of the blood vessel as well. And all that leads to thickening of the blood vessels and narrowing of that space. And you do get that significant 15 to 20% reduction of cerebral blood flow being pumped to the brain during an apnea. So no question, many, many reasons why untreated sleep apnea increases stroke risk. Right. Oh, Sleepy has jumped to the lead. So we got a real contest here. All right. Chiari malformations are associated with which of the following? Chiari malformations are where the it's kind of the central lower part of the cerebellum, where those naturally sit lower and go down through the foramen magnum, the hole at the base of the skull, depression of the brainstem. And that condition has been associated with increased risk for obstructive sleep apnea, central sleep apnea, headaches, or all of the above. All right, got several answers coming in. More seconds. Yes, very good. You know, it definitely leads to all those issues. You do see a higher incidence of both, in particular compression of the brainstem or respiratory centers, and headache is a very common complaint with Chiari malformations. See that in someone's medical history. Definitely something to be on the lookout for during their sleep study, is monitoring for not only obstructive sleep apnea but also sleep apneas. Right. All right, Sleepy's hanging in there. Droopy's close behind. Which of the following conditions are not considered contraindications to utilizing a home sleep study? Neuromuscular disease, chronic opioid use, epilepsy, or all of the above are contraindications? All right, got our answers coming in. Still a little bit of time. And neuromuscular disease, that's different conditions. It's a whole category. It's things like amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease. can be myasthenia gravis, where you get a weakness at the actual neuromuscular junction from antibodies binding to that and impairing neurotransmission. So the answer is, yeah, I tricked you on this one. That was on purpose. I wanted everybody to go for the all of the above. Epilepsy is actually not a contraindication to using a home sleep study. Now, if the question is, are these events seizures or are they something else, then obviously you'd want to use a PSG. But just if the question is whether or not it's contraindicated for just detecting obstructive sleep apnea, it's not. So in those circumstances, it is fine to use that. Neuromuscular disease, they're susceptible to a lot of hypoventilation. So anytime you're at a situation, just like with chronic opioid use, so anytime you have that scenario, you really want to bring them into the lab to be monitored because you don't know what that baseline oxygen level is going to be. So you can, have your oscillation with your obstructive sleep apnea, but those you're really looking for that lower baseline as well, which can certainly be an indication that you might need a different type of therapy or potentially supplemental oxygen. All right. Sleepy and Droopy are hanging in there. Not sure where the rest of the dwarves are, but all right. Which of the following medications can be used to treat cataplexy? Cataplexy we most commonly associate it with narcolepsy, where you'd actually develop muscle weakness associated with an emotional state. Don't forget, cataplexy is not sleepiness, it's actual muscle weakness. Those medications that are the options are modafinil, trazodone, solriamfetol, and pitolisant. Okay? Which of those can be used to treat cataplexy? Got some answers coming in. Just a few more seconds if you haven't made a selection. All right. So pitolisant, and that's the reason I included this. It's not a medication a lot of people include. Yeah, no, I was mean. On a lot of them, I designed them specifically just to kind of trip everybody up. Like I said, this is just for play. Armodafinil is a medication you do commonly see associated with treatment of narcolepsy or excessive daytime sleepiness conditions. It blocks the reuptake of those stimulant neurotransmitters, so you can. It leads. The net result is it leads to wakefulness. Trazodone is more of a sleep aid. You use that. It's an antidepressant that sometimes can be used to address insomnia complaints. I can go ahead and show you a slide here too. Solriamfetol is a dopamine and norepinephrine reuptake inhibitor, but that's primarily effective for the treatment of excessive daytime sleepiness with narcolepsy, much like the armodafinil. Okay. Pitolisant increases histaminergic neurotransmission, and that helps address excessive daytime sleepiness, but it's also been found to help with cataplexy. So, no question, the medicine you more commonly hear about being used for cataplexy is the sodium oxybate or the newer form with the lower sodium content, or Xywav. That's commonly the first thing that comes to mind when you think of treating people with really problematic cataplexy. But don't forget also, even before you have to go to that step, a lot of people can be successfully treated with things like SNRI antidepressants like venlafaxine. So that's serotonin norepinephrine reuptake inhibitors. Okay. Untreated OSA tends to have which effect on sleep architecture? Increased in 2 sleep and decreased in 3 and REM? Increased in 1 and REM sleep? Decreased WASO and in 2 sleep? Or decreased sleep fragmentation? All right, got our answers coming in. And I've heard a few. All right, so let's see how people did on this one. Very good. Yeah, absolutely, because it leads to more fragmentation. You tend to get more into sleep, less into those deeper stages of sleep. N3, also less REM sleep. It tends to increase wake after sleep onset, of course, and you tend to get increased sleep fragmentation. And as far as REM sleep goes, it definitely tends to decrease that. And then when you treat it, that's when I'm sure you've all seen on sleep studies before where you start the CPAP and then, holy cow, they go into all these multiple long stage REM phases. And it's because they're relatively REM deprived, because the brain knows when you're in stage REM sleep, obviously you don't have all the accessory muscles working, so you don't have as much assistance with your breathing, and it's easier to dip lower with your oxygen desaturations. Breathing events are more frequent for many, many individuals. So the brain will selectively kind of keep you out of stage REM sleep, and then all of a sudden, treated with CPAP, we can go into stage REM sleep and do well. So it'll keep you more into stage REM, leading to that stage REM rebound. All right. Everybody's hanging in there. We've got a good horse race there. Which of the following is not true regarding motor vehicle crashes in the setting of sleep apnea? The diagnosis of sleep apnea carries a 2 to 3-fold increased risk of motor vehicle crashes. The degree of hypoxemia correlates with the rate of the MVCs. Complaints of excessive daytime sleepiness correlate more with the MVCs than does the BMI elevation. Or all of these are true. All right, got some answers coming in. A few more minutes to enter your choice. All right, yes, another trick question. It's kind of interesting with motor vehicle crashes. Yes, it does carry, the diagnosis of sleep apnea does carry a 2 to 3-fold increase in the risk. The degree of the hypoxemia or the desaturations does tend to correlate with an increased risk. And as far as the daytime sleepiness and the BMI, and there may be a reason for this, but the BMI elevation actually correlates more with the motor vehicle crash rate than do complaints of excessive daytime sleepiness. And if you think about it, there may be a reason for which one is subjective and which one is objective, right? So a lot of times people underestimate their daytime sleepiness because that's the norm for you. That's the way you've lived for years. That's the way you think people normally function, is to go around in a slight fog or haze. It's because you've lost insight into that fact. Much like people who are sleep deprived lose insight into the fact that they're sleep deprived and that their response times are slower and things like that. And it doesn't have to be that much. Like with sleep deprived individuals, even if you restrict them to just 6 hours on a regular basis, they do not typically have insight into the fact that they have slower reaction times, slower thought processing, and so forth. Which of the following antidepressants would be best at not exacerbating restless leg syndrome? It's a well-known phenomenon that antidepressants tend to make restless legs worse. So which of these an antidepressant in the setting of restless leg syndrome, which of these would be the best in general to be on? Fluoxetine, bupropion, imipramine, or venlafaxine? Coming in. Everybody's thinking about it. And the answer is bupropion, right? You got it. Because the SRI, the serotonin-specific reuptake inhibitors, like fluoxetine, the SNRIs, like venlafaxine, where it's serotonin and norepinephrine reuptake inhibitors. Imipramine is an older tricyclic antidepressant. Those definitely can be associated with exacerbation of restless legs. Bupropion has its primary effect through dopaminergic effects. So in general, it definitely tends to cause far less of restless leg exacerbation as compared to the others. It's kind of an interesting medication. It can also be used for mild ADHD. It can help in those kind of situations. It also can sometimes be used to help people with smoking cessation. It does have some modest benefit in that regard as well. It's kind of an interesting choice. All right, Sleepy and Droopy hanging in there close together with several close behind. All right. Which of the following conditions is not associated with an increased incidence of restless legs? Osteoarthritis, peripheral neuropathy, anxiety, or ADHD? All right, got some answers coming in. And yes, there are many, many, many associations with restless legs. We'll go over that here in just a sec. All right, let's see how many people got it. Okay, kind of spread out across the different answers. Yeah, it's arthritis, actually. Interestingly, rheumatoid arthritis, restless legs, but not so much osteoarthritis. So, kind of an interesting factoid there. Oh, Jen is moving up. So let's take a look. These are in no specific order, but many, many conditions are associated with RLS, including a lot of neurological disease, narcolepsy, multiple sclerosis, Parkinson's disease, migraine, also COPD, ADHD, peripheral neuropathy, very commonly associated, also very commonly confused, cardiovascular disease, sleep apnea, diabetes, fibromyalgia, rheumatoid arthritis, as I mentioned, nocturnal eating syndromes, depression, anxiety, obesity is associated with increased risk for RLS, panic disorder, PTSD, thyroid disease, chronic kidney disease, and another really biggie is iron deficiency, so much so that anytime you see someone with RLS, you definitely want to check for iron deficiency, because oftentimes merely repleting their iron stores will address the restless legs for them. And it can just be a relative deficiency. Okay, it doesn't have to be just an overt deficiency. All right, along those same lines, which of the following is associated with periodic limb movements asleep? Epilepsy, COPD, improvement if treated with SSRIs, or anxiety. All right, anxiety. So yes, definitely, much like restless leg syndrome, a lot of different things are associated with periodic limb movements. Two of the most common of which are restless leg syndrome and obstructive sleep apnea. But it can be a lot of other things. Again, common theme, a lot of neurological disease like dopa-responsive dystonia or DRD, not something you see a whole lot of. Multiple system atrophy, neurodegenerative disease. Mood disorders, so like anxiety and depression. ADHD, PTSD, the RLS and OSA as I mentioned. Oppositional defiant disorder, sleep-related eating, multiple sclerosis, Asperger's syndrome, end-stage renal disease, congestive heart failure, Parkinson's, sickle cell anemia, spinal cord injury tends to lead to a lot of periodic limb movements, and the medications that commonly increase sleep are your antidepressants like SSRIs and tricyclic antidepressants. Also, dopamine agonists can be associated with those. There are other individuals where you can actually see improvement on dopamine agonists. And lithium is also commonly associated with increased PLMs. All right, which of the following would be the least desirable medication to use for regular nightly RLS symptoms? Okay, you'll see all four of these used for it, but which one would be the least desirable? The rotigotine patch, gabapentin, carbidopa-levodopa, or pramipexole? So the rotigotine patch is a dopamine agonist patch. Pramipexole is a dopamine agonist. Carbidopa-levodopa is dopamine, basically. It's metabolized in the body to lead to dopamine. And gabapentin is an anticonvulsant medication, alpha-2 delta ligand that can be used. So the answer is, and the majority got this, or a plurality got this, carbidopa-levodopa. And the reason why is because up to 60%, and in some studies as much as 2/3 or more of people treated with carbidopa-levodopa or Sinemet on a nightly basis will develop augmentation on their restless leg symptoms. And that's where you don't just have it when you go to bed, you get it several hours beforehand, okay? So the RLS can actually start in the afternoon or evening hours, okay? And usually it takes a little time for that to develop, usually several months. Augmentation can develop, but in my opinion, to a much, much lesser degree on the dopamine agonists like the pramipexole or ropinirole, and much less so on the rotigotine patch because of the delivery mechanism, usually throughout an extended period. Augmentation can affect other parts of the body, including arms even, okay? And you see more of the augmentation complaints in individuals with a family history of restless legs. Yes, sir.
Didn't I hear you say at another conference that it took so long to send them out that none of the others would work after that?
That can be the case. No, that's more with the opioids. Yes, that's the one that kind of changes their responsiveness to other medications. But you can make it a little more difficult to use the other dopamine medications. Impulse control disorders are a potential side effect of which class of medication used to treat restless leg syndrome? Dopamine agonists, benzodiazepines, alpha-2 delta ligands like gabapentin, or iron therapy. Okay, impulse control disorders are things like where people tend to start gambling, or they can have, other addictive type behaviors that develop de novo or of new onset on the medication. So it's actually the dopamine agonists. Okay. Is more so with them than the carbidopa-levodopa, the benzodiazepines, medications like gabapentin and iron. Dopamine agonists, it's a question you have to ask if they're on that, because it does happen where individuals on medications like pramipexole, ropinirole, or rotigotine can actually develop this impulse control disorder, and that can happen in up to anywhere from 6 to 17% in the literature. So definitely something to be aware of. And just yet another reason why in recent years gabapentin has kind of moved more toward first-line therapy for restless legs. For a long time it was the dopamine agonists that we tended to go to first. All right, this actigraphy report, and it may be a little small, but so on this one, the yellow is your activity, and the blue is the decreased periods of activity, and this line right here is about 12 midnight, about right here. So this kind of ties in with our earlier talk. So what do you think this more than likely represents? Shift work disorder, insufficient sleep, delayed sleep phase, or free running sleep-related sleep disorder? Got some answers coming in. Yeah, it's delayed sleep phase primarily. There may be a little bit of a component of insufficient sleep, but if you look on subsequent nights, a lot of times they get some recovery sleep. So that may very well have been, they had to get up and go somewhere to do something, and then caught up a bit on the weekends. But yeah, that going to bed after midnight on a fairly consistent basis, and then having that sleep extend over into the morning hours is consistent with the delayed sleep phase type. All right, so we got a little bouncing around still with the scores. Right. Sleepy's hanging in there. Which of the following is not true regarding insomnia? Chronic insomnia affects about 25 to 35% of the population. Chronic insomnia must last for 3 months. Episodic insomnia can be recurrent, or all of the above. Got some answers coming in. All right. So, chronic insomnia affects 25 to 35% of the population. Well, it's common, but chronic insomnia, where it lasts longer than 3 months, is not quite that common. It affects about 10 to 15% of the population. Episodic insomnia, where you have it from time to time, affects about 25 to 35%. So very, very common for individuals to have insomnia at least occasionally. And don't forget that, to make that connection, it is chronic insomnia. It does last longer than or equal to 3 months. Which of the following is incorrectly paired? Delayed sleep phase, and treating that with melatonin given 1 hour before the desired bedtime. Advanced sleep phase and morning bright light therapy. Non-24-hour sleep-wake rhythm and tazimelteon. And jet lag with westward travel being treated with evening bright light for about 3 days in advance to travel. Okay, for advanced sleep phase, in general, you want evening bright light therapy. And I did hear someone point out it was a little bit of trickery. This was kind of the best answer, but yes, for the melatonin, I heard somebody mention it. Ideally, it is a couple hours before in general, but still, 1 hour before is better than using morning bright light therapy for advanced sleep phase. So for advanced sleep phase, you want to expose them to light in the evenings. All right. Which condition is most commonly associated with REM sleep behavior disorder? Alzheimer's disease, Parkinson's disease, Huntington's disease, or complex partial epilepsy? That's right. It's funny because these talks, actually, they're cumulative. Over the last 4 or 5 years, you've heard the answers to these questions. So I know it's kind of not fair unless you've been here for 4 or 5 years in a row. If you've been here for the past four years, you've heard all these answers. A few more seconds. Looks like we still have a few people waiting to answer. Oh, the synuclein? Synuclein? Hang on just a second, you'll see. Yes, exactly. Parkinson's disease. So very good. Definitely the majority got that. And should be right here. This next. There it is. Yes, so appropriate that you mentioned it. The synucleinopathies, it's a protein that's deposited with these conditions, is associated with both the disease pathology and some of the things that it causes. And those that family, that group of conditions are Parkinson's disease, dementia with Lewy bodies, multiple system atrophy, so those different neurodegenerative diseases. Which of the following characteristics is associated with non-REM parasomnias? Typically, individuals have good recall of events. Triggers of these parasomnias include excess sleep. It occurs more in stages in stage N3, much more commonly than stage N2, or all of the above. A few more answers coming in. Few more seconds. All right, yep, another trick, all of the above question. They do not typically have good recall of the events. That's one hallmark of non-REM parasomnias. Usually they don't recall that. In fact, even to the point that you can ask them about it the next day and they say, no, I didn't do that, you know. Sleep deprivation is a common trigger rather than excess sleep. It does occur more commonly in stage N3, slow wave sleep, especially an hour or so into a night's rest. You see a lot more of that. All right. Okay, I got some position changes going on here. All right, a few more slides to go. Which of the following is not a possible treatment for somnambulism or sleepwalking? Sleep deprivation avoidance, clonazepam, a benzodiazepine, anticipatory awakenings, or montelukast. Montelukast is a medication commonly used for allergy, allergic rhinitis, those kind of issues. Anticipatory awakenings is where you go in about an hour or so during after someone's gone to sleep. You kind of stir them just a bit, and that really can reset the sleep stages and kind of bring them out of slow wave sleep. Got a few more seconds. Montelukast, exactly. So the benzodiazepine can definitely be used for that. Avoiding sleep deprivation, that's a known trigger for sleepwalking. And different medications have been associated with sleepwalking, one of which is montelukast or Singulair, the allergic rhinitis medication. Also commonly sodium oxybate, antidepressant medications, beta blockers, quinolone antibiotics, the ones that end in floxacin, and the non-benzodiazepine GABA agonists like zolpidem, zaleplon, zopiclone. Right, just a couple more slides here. Which EEG finding can be seen preceding the arousal associated with non-REM parasomnias? And you can see it in this slide. Sorry, it's supposed to be a little bigger than this, but see these kind of higher amplitude waves here before the parasomnia onset happens here? Triphasic waves, hypersynchronous delta sleep, centrotemporal spikes, or sawtooth waves. a very specific EEG related PSG question. Just a few more seconds. Those are hypersynchronous delta waves. Okay, it's compressed a little bit there, but that's what that is. Triphasic waves you see with confusional states, encephalopathies, sawtooth waves usually before rapid eye movement or REM episodes, and centrotemporal spikes are associated with different epilepsy syndromes. All right, still a little movement going on. All right, and there's just that hypersynchronous delta. Okay, just a couple more questions. Which of the following strategies are effective in improving nighttime sleep in the elderly? Encouraging physical activity during the day, avoiding diuretics before bedtime, part of the day on a regular basis, or all of the above? All right. Most of our answers are in. So I'm going to skip ahead in the interest of time. And yes, absolutely, very good. All of the above. Definitely those can help with nighttime sleep. All right. Next to last, which functions can this newly developed device serve to provide? Has everyone seen one of these yet? It's a little apparatus that goes in between the mask and the tubing connection. And it's got 4 holes in the center, 4 smaller diameter holes. Oh, sorry, I don't know. I guess I advanced the slide before I gave you a chance to look at it. Sorry about that, so I spoiled the surprise. Yeah, that device is called the VCOM, and it serves to soften peak inspiratory flow. So for a lot of people who are having trouble tolerating the flow, it can really decrease that, decrease mouth breathing, can help with noise reduction, and can also decrease leak. So it can be quite effective for a number of different things. Sleep res, yeah. I can show you one if you want to see one. All right. So they are. Yeah, you can wash it. It's just plastic. And here's the last question. And this can be multiple answers. Which of the following pairings is most appropriate for later this month? Cranberry sauce and stuffing, cranberry sauce and dressing, cranberries and stuffing, or cranberries and dressing? I don't, actually. My wife does, but I don't. So she's told me there's definitely a correct answer. That's right. All right. So, and we're actually getting some answers on this. Yeah, they're all correct. So, contrary to what she told me, according to her, it's cranberry sauce and dressing. But, all right. Well, so let's see who won. In third place, we have Flipper. Second place, we've got Insomnia Queen. And number 1 is Sleepy. Congratulations, Sleepy, whomever you are. All right. Thanks, everybody. I know that was very, very different. I just thought it might be kind of fun to do something different, to hear a lot of different little random points that we've talked about over the past several years. And I hope you enjoyed it. Sorry for any technical problems whenever you try something new. Sometimes the internet connection can throw a curveball your way. All right.
Thank you so much,
Absolutely.
Dr. Tallent. That was fun. I learned some things.